All right, today we're diving into the professional's playbook for patient-controlled analgesia, or PCA. Now, this is an incredible tool that literally puts pain management into the patient's hands. But with that power comes a huge responsibility. You see, its effectiveness and, most importantly, its safety all come down to a strict professional approach, a constant balancing act between patient control and our critical clinical safeguards.
So, here's our game plan. We're going to cover 5 key areas. First, we'll get down to the basics, what PCA actually is. Then we'll get into the non-negotiable rules of monitoring. We'll break down the duties for the whole team, clarify some absolutely crucial medication protocols, and finally, we'll talk about how to spot those red flags that tell you it's time to act.
Okay, first things first. Let's make sure we're all on the same page. What exactly is patient-controlled analgesia, and where does it fit into our toolkit for patient care?
So at its heart, PCA is a system that gives the patient direct control over their pain medication. It's designed specifically for short-term, severe pain. It lets the patient push a button and give themselves a dose of relief right when they feel they need it. But, and this is key, it's all within carefully programmed limits that we set.
But, and I can't stress this enough, this is not a one-size-fits-all solution. A real professional approach means knowing exactly when to use it and when to steer clear. It's fantastic for that acute, intense pain you see after surgery, with traumatic injuries, or in things like a sickle cell crisis. On the flip side, you have to avoid it for chronic pain or if a patient has cognitive issues or any kind of respiratory depression. That judgment call is the first, most important step in keeping your patient safe.
All right, let's get into what is arguably the most critical part of this whole playbook, monitoring. Look, PCA is not a set-it-and-forget-it kind of deal, not even close. It demands constant, active vigilance from every single one of us on the clinical team.
So what are we looking for? Well, a thorough assessment is absolutely non-negotiable. We're talking regular checks of blood pressure, respiratory rate, and of course their pain level. But just as important, we have to assess their level of consciousness using the AVPU scale. You know, are they alert, responding to voice, responding to pain, or are they unresponsive? This gives us a quick, vital snapshot of their mental state. And of course, you've got to be checking the data from the pump itself. How often are they actually using it?
Now, here's where the process gets really dynamic, because how often you check escalates with the risk. For an unstable patient, you're in there every single hour. If they're stable, you can adjust that to every 2 hours. But, and listen to this, if you have any concern about a potential overdose, that monitoring skyrockets. You're checking them every 5 minutes. Your vigilance has to match the risk level moment to moment.
You know, safe PCA is never, ever a one-person show. It's all about teamwork. It's a collaborative safety net we build around the patient, where everyone has a distinct and vital role to play. And that safety net starts with the prescriber. Their number one job? Absolute clarity. They have to tell the nursing staff about any and all changes to that prescription. Just putting it in the computer isn't enough. You have to communicate. And that documentation has to be perfect, clear, timely, and the single source of truth for the entire team. No ambiguity allowed.
Then you have the nurse's role, which is so hands-on and full of checks and balances. Setting up a new PCA, that requires a dual signature, 2 nurses checking everything is correct. The administration has to be witnessed and charted. And at every single handover, you are checking that pump settings against the prescription. It's this constant loop of assessment and verification that really serves as the frontline defense for the patient.
And this just perfectly illustrates the why behind our procedures. A true professional doesn't just follow rules blindly. They understand the reason. So why do we change the IV line every 24 hours? It's not just a random rule. It's a very specific clinical action we take to slash the risk of microbial growth and protect our patient from a nasty infection.
Okay, let's talk meds. Because what a patient is given alongside their PCA is every bit as important as the PCA medication itself. Getting this right is a cornerstone of patient safety. Think of it like this. There are supportive meds and there are dangerous ones. On the supportive side, regular paracetamol is great. Antiemetics for nausea, laxatives for constipation, these are all good. And you absolutely must have naloxone available as needed as a safety net. But on the other side of that line is a hard stop. You must avoid prescribing other opioids like oxycodone or morphine. You start mixing those and the risk of toxicity and respiratory depression goes through the roof. Now, like with many rules, there is one very specific exception. You can see other opioids prescribed, but only as part of a formal, documented plan when you are actively weaning a patient off the PCA.
It has to be a controlled, planned transition to get them safely onto oral pain relief, not just a casual addition.
And that brings us to our last and honestly maybe our most important section. Being a pro isn't just about knowing how to manage a treatment. It's about knowing exactly when it's time to stop, whether that's because of a great recovery or because of an emergency.
So let's just ask the question straight up. When do you stop the PCA? And the answer isn't simple because there are two totally different situations we have to be ready for.
So first, let's talk about the good reason to stop. Positive progress. This is the goal, right? We stop the PCA when the patient is clearly getting better. They can eat and drink, they're transitioning to oral pain meds, their pain score at rest is down below a 4, and they can actually move around comfortably. This is a win. This is the therapy working as intended. Okay, now for the other side of the coin, the emergency stop. If you see any one of these signs, you stop the PCA immediately. No hesitation. If their respirations drop below 8 a minute, if they go from being alert to only responding to pain, or if they become unconscious, these are massive, critical red flags that scream potential overdose.
And in that emergency, you don't have time to think. You just need to act. The protocol is crystal clear. Step 1, stop and remove the PCA immediately. Step 2, escalate. Get the anesthetist or the doctor in there for an urgent review. And step 3, if it's needed and prescribed, you administer naloxone to reverse the opioid's effects. Simple, swift, and life-saving.
And all of this brings us back to the fundamental question at the heart of the entire playbook, doesn't it? PCA is amazing because it gives patients comfort and autonomy. But as we've just laid out, that autonomy has to be wrapped in layers and layers of our professional vigilance. So the question I'll leave you with is this. As professionals, how do we constantly get better at striking that perfect balance between empowering our patients and exercising the rigorous clinical caution that their safety absolutely demands?